Your body is storing fat in locations that standard measurements cannot detect. This accumulation is not occurring in the subcutaneous tissue beneath your skin, where adipose deposits become visibly apparent, but rather in deeper compartments surrounding your organs, infiltrating your liver tissue, and depositing within muscle cells where it interferes with metabolic function. These ectopic fat deposits, meaning fat stored in locations where it does not belong physiologically, are creating insulin resistance, promoting inflammation, and elevating your risk for cardiovascular disease, type 2 diabetes, and metabolic dysfunction. The concerning aspect of this phenomenon is that it can occur in individuals whose body mass index falls within the normal range, whose weight appears healthy on standard scales, and whose outward appearance provides no indication of the metabolic disruption occurring internally. The challenge presented by ectopic fat accumulation stems from the inadequacy of conventional body composition assessment methods. Body mass index, which remains the most widely used metric in clinical practice and public health guidance, calculates a ratio of weight to height without distinguishing between lean tissue and adipose tissue. An individual can maintain a body mass index within the recommended range of 18.5 to 24.9, while simultaneously carrying dangerous amounts of visceral fat around their organs and intramuscular fat within their skeletal muscle. This condition, sometimes referred to as metabolically obese normal weight or colloquially as being thin outside but fat inside, affects an estimated 20 to 30% of individuals classified as normal weight based on body mass index alone. For several decades, obesity research and clinical guidelines have focused primarily on total body weight and body mass index as the determinants of metabolic health. The operating assumption held that individuals maintaining normal weight were metabolically healthy and faced minimal risk for obesity-related diseases, while metabolic disease risk was confined primarily to those with elevated body mass index. Medical screening, insurance assessments, and public health interventions were structured around body mass index thresholds, with normal weight individuals receiving minimal scrutiny regarding their metabolic status. This framework has proven fundamentally inadequate, as research has revealed that fat distribution and metabolic function are far more critical determinants of disease risk than total body weight, body mass index. What metabolic research has now established through imaging studies, metabolic testing, and longitudinal health outcomes is that body fat percentage, and particularly the location of fat storage, determine metabolic health to a far greater extent than body mass index. Individuals with normal body mass index but elevated body fat percentage, particularly when that fat is concentrated viscerally rather than subcutaneously, demonstrate metabolic dysfunction comparable to or exceeding that of individuals classified as overweight or obese by body mass index standards. They develop insulin resistance at similar rates, experience cardiovascular events at similar frequencies, and progress to type 2 diabetes, with comparable incidence despite maintaining what clinical guidelines define as healthy weight. I am Dr. Alex, an emergency medicine physician. Throughout nearly 10 years of clinical practice in accident and emergency departments, I have observed the consequences of metabolic disease in individuals across the entire spectrum of body weights and compositions. The patient in their 40s presenting with myocardial infarction, whose body mass index of 23 provided false reassurance regarding cardiovascular risk. The individual with newly diagnosed type 2 diabetes, whose normal weight had obscured the visceral adiposity and insulin resistance that had been developing for years. The patient with non-alcoholic fatty liver disease, whose external appearance gave no indication of the hepatic fat accumulation, creating progressive liver dysfunction. My objective is to help individuals understand that metabolic health cannot be assessed through weight and body mass index alone, and that body fat percentage and distribution must be considered to accurately evaluate disease risk and implement appropriate preventive strategies. For the next several minutes, we need to examine the specific mechanisms through which body fat percentage and distribution determine metabolic health independent of total body weight, because once these relationships are understood, the inadequacy of body mass index as a health metric becomes evident, and the need for more comprehensive assessment becomes clear. Before discussing the problems created by elevated body fat percentage in normal weight individuals, we need to establish what constitutes healthy body composition and why fat distribution matters. Adipose tissue is not a passive storage depot, but rather an active endocrine organ that produces hormones and inflammatory signaling molecules. The metabolic effects of adipose tissue depend critically on where that tissue is located. Subcutaneous fat, which is stored beneath the skin and comprises the majority of visible adipose tissue, is relatively metabolically benign when not excessive. It provides insulation, energy storage, and cushioning without substantially impairing metabolic function in most individuals. Visceral fat, which is stored within the abdominal cavity surrounding the liver, intestines, and other organs, produces dramatically different metabolic effects despite being composed of the same cell type. Visceral adipocytes are more metabolically active than subcutaneous adipocytes, releasing higher levels of free fatty acids directly into the portal circulation that drains into the liver. This creates hepatic insulin resistance and promotes hepatic glucose production. Visceral fat also produces higher levels of inflammatory cytokines, including interleukin-6 and tumor necrosis factor alpha, which enter systemic circulation and create inflammation throughout the body. The inflammatory signaling from visceral fat impairs insulin sensitivity in muscle and other tissues, creating the systemic insulin resistance that characterizes metabolic syndrome. Ectopic fat refers to adipose accumulation in tissues not designed for fat storage, including the liver, skeletal muscle, pancreas, and heart. Hepatic steatosis or fatty liver occurs when triglycerides accumulate within liver cells beyond the normal minimal amounts. This impairs hepatic insulin sensitivity and glucose regulation while promoting inflammation that can progress to non-alcoholic steatohepatitis and eventually cirrhosis. Intramyocellular lipid, which is fat stored within muscle cells, directly interferes with insulin signaling pathways in those cells, creating muscle insulin resistance that impairs glucose uptake. Pancreatic fat accumulation has been associated with beta cell dysfunction and reduced insulin secretory capacity. Epicardial fat, which surrounds the heart, produces inflammatory mediators that promote coronary atherosclerosis. What becomes evident when fat distribution is understood through this framework is that total adipose mass matters far less than where that adipose tissue is located. Two individuals with identical body weight and body mass index can have radically different metabolic profiles based on whether their adipose tissue is stored primarily subcutaneously or whether substantial amounts are stored viscerally and ectopically. The individual with predominantly subcutaneous fat storage may maintain normal insulin sensitivity, normal inflammatory markers, and low cardiovascular risk, despite being classified as overweight by body mass index standards. The individual with substantial visceral and ectopic fat, despite normal body mass index, demonstrates insulin resistance, elevated inflammatory markers, and significantly elevated disease risk, despite being classified as normal weight. At this juncture, if you are viewing this presentation, you are likely concerned about metabolic health and seeking evidence-based guidance that extends beyond conventional weight-focused recommendations. I want to establish a clear commitment regarding the content provided through this channel. I will continue producing material grounded in current metabolic research and clinical evidence to help individuals understand the actual determinants of metabolic health rather than relying on oversimplified metrics. The request I make is that you consider subscribing to support the expansion of this evidence-based content to additional individuals who would benefit from more nuanced health information. If you reach the conclusion of this presentation and determine it did not provide valuable insights beyond conventional recommendations, you are welcome to unsubscribe. However, if you find the mechanistic explanations and practical applications useful, your subscription helps extend the reach of this information. Please consider subscribing now, and we will continue with a detailed examination of how body fat percentage and distribution determine metabolic health. The first mechanism through which elevated body fat percentage in normal weight individuals creates metabolic dysfunction involves hepatic fat accumulation and insulin resistance. The liver plays a central role in glucose and lipid metabolism, storing glucose as glycogen after meals and releasing glucose during fasting periods to maintain blood sugar stability. The liver also synthesizes triglycerides and packages them into very low-density lipoproteins for transport to other tissues. When excess calories are consumed, particularly from refined carbohydrates and fructose, the liver converts these nutrients into fat through a process called de novo lipogenesis. Under normal circumstances, this newly synthesized fat is packaged and exported. However, when calorie excess is chronic or when insulin signaling becomes impaired, triglycerides begin accumulating within liver cells themselves. Non-alcoholic fatty liver disease is defined as hepatic triglyceride content exceeding 5% of liver weight in individuals who consume minimal alcohol. This condition affects approximately 25% of adults in developed countries and is increasingly recognized in individuals with normal body mass index. The accumulation of fat within liver cells has several metabolic consequences. First, it creates hepatic insulin resistance, meaning the liver becomes less responsive to insulin's signal to suppress glucose production. This results in inappropriately elevated glucose output from the liver even when blood glucose is already adequate, contributing to fasting hyperglycemia and overall glucose dysregulation. Second, hepatic steatosis promotes increased production of very low-density lipoproteins carrying triglycerides, leading to elevated serum triglycerides and reduced high-density lipoprotein cholesterol. This dyslipidemic pattern, characterized by high triglycerides and low high-density lipoprotein, substantially elevates cardiovascular disease risk independent of low-density lipoprotein cholesterol levels. Third, fatty liver creates a pro-inflammatory hepatic environment where inflammatory cytokines are produced and released into systemic circulation, promoting insulin resistance in peripheral tissues and contributing to systemic inflammation. The progression from simple steatosis to non-alcoholic steatohepatitis involves inflammatory cell infiltration and hepatocyte damage that can ultimately lead to fibrosis and cirrhosis. The concerning aspect of hepatic steatosis in normal weight individuals is that it often goes undetected because the condition is not suspected in the absence of elevated body mass index. Liver enzymes measured on standard blood tests may remain normal or show only mild elevation even when substantial fat accumulation is present. Diagnosis requires imaging studies such as ultrasound, computed tomography, or magnetic resonance imaging, or specialized techniques such as transient elastography that are not routinely performed in normal weight individuals. Consequently, many individuals maintain normal weight while developing progressive fatty liver disease that creates insulin resistance and metabolic dysfunction years before diabetes or cardiovascular disease becomes clinically apparent. The second mechanism involves visceral adiposity and inflammatory cytokine production. Visceral fat depots, particularly the omental and mesenteric fat surrounding abdominal organs, demonstrate substantially higher inflammatory activity compared to subcutaneous fat. Visceral adipocytes produce elevated levels of interleukin-6, tumor necrosis factor alpha, monocyte chemoattractant protein 1, and other pro-inflammatory mediators. These cytokines enter the portal circulation and reach the liver at high concentrations, where they impair insulin signaling and promote hepatic glucose production and lipogenesis. They also enter systemic circulation, where they create insulin resistance in skeletal muscle, promote endothelial dysfunction in blood vessels, and contribute to the chronic low-grade inflammation characteristic of metabolic disease. The inflammatory state created by visceral fat has consequences extending beyond insulin resistance and glucose metabolism. Chronic inflammation promotes atherosclerosis through multiple mechanisms including endothelial activation, increased adhesion molecule expression, oxidative modification of low-density lipoprotein cholesterol, and promotion of foam cell formation in arterial walls. Inflammatory cytokines also promote a prothrombotic state with increased clotting factor production and reduced fibrinolysis, elevating risk for thrombotic events including myocardial infarction and stroke. Additionally, chronic inflammation from visceral fat has been implicated in cancer development through mechanisms including DNA damage from reactive oxygen species, impaired immune surveillance, and promotion of angiogenesis that supports tumor growth. Individuals with normal body mass index can carry substantial visceral fat if their lean tissue mass is low. Sarcopenia, which is loss of muscle mass, reduces total body weight while visceral fat remains preserved or even increases. This creates a situation where body mass index remains in the normal range, but body composition has shifted dramatically toward higher fat percentage and particularly higher visceral fat percentage. This phenomenon becomes increasingly common with aging as muscle mass naturally declines if not actively maintained through resistance exercise and adequate protein intake. The result is metabolically obese normal weight individuals whose disease risk profiles more closely resemble those of obese individuals than healthy normal weight individuals, despite maintaining weight within recommended ranges. The third mechanism involves intramyocellular lipid accumulation and muscle insulin resistance. Skeletal muscle is the primary site of insulin-stimulated glucose uptake. accounting for approximately 70 to 80% of glucose disposal after meals. When muscle cells function normally, insulin binds to receptors on the muscle cell surface, triggering a signaling cascade that causes glucose transporter proteins to move from inside the cell to the cell membrane, where they facilitate glucose entry into the cell. The glucose is then either oxidized for energy or stored as glycogen for future use. This process maintains blood glucose within normal ranges following carbohydrate consumption. When fat accumulates within muscle cells as intramyocellular lipid, it interferes with this insulin signaling pathway at multiple points. Lipid metabolites, including diacylglycerols and ceramides, activate protein kinases that phosphorylate insulin receptor substrate proteins in ways that impair their function, reducing the downstream signaling cascade that would normally promote glucose uptake. Additionally, mitochondrial function becomes impaired in muscles with excessive intramyocellular lipid accumulation, reducing oxidative capacity and contributing to lipid accumulation through reduced fat oxidation. The result is muscle insulin resistance, where normal insulin levels produce inadequate glucose uptake into muscle tissue. This muscle insulin resistance has several consequences for whole body metabolism. Blood glucose remains elevated longer after meals because muscle cannot effectively clear it. The pancreas compensates by producing more insulin, creating hyperinsulinemia that drives further metabolic dysfunction. The chronically elevated insulin promotes additional fat storage, further exacerbating insulin resistance. Eventually, the pancreatic beta cells become unable to maintain the hyperinsulinemia required to compensate for insulin resistance, and blood glucose rises into the prediabetic and diabetic ranges. Throughout this progression, which can span years or decades, body weight may remain stable and body mass index may remain normal, providing false reassurance that metabolic health is maintained. Intramyocellular lipid accumulation occurs when fatty acid delivery to muscle exceeds the muscle's capacity to oxidize those fatty acids for energy. This can result from excessive calorie intake, particularly from refined carbohydrates that are converted to fat in the liver and released as very low-density lipoprotein triglycerides. It can also result from physical inactivity, which reduces muscle oxidative capacity and fat oxidation rate. Importantly, intramyocellular lipid accumulation can occur in normal weight individuals who consume excessive refined carbohydrates and remain sedentary despite maintaining energy balance prevents weight gain. Their muscle cells accumulate fat that creates insulin resistance independent of total body weight or body mass index. The fourth mechanism involves pancreatic fat infiltration and beta cell dysfunction. The pancreas contains specialized beta cells within the islets of Langerhans that produce and secrete insulin in response to elevated blood glucose. These beta cells must maintain the capacity to produce sufficient insulin to match the body's insulin requirements, which increase when insulin resistance develops in liver, muscle, and adipose tissue. Fat accumulation within the pancreas, either as adipocytes infiltrating between pancreatic tissue or as lipid accumulating within pancreatic cells themselves, has been associated with impaired beta cell function and reduced insulin secretory capacity. The mechanisms through which pancreatic fat impairs beta cell function are not completely understood, but appear to involve lipotoxicity, where excessive lipid exposure damages beta cells through oxidative stress, endoplasmic reticulum stress, and inflammatory signaling. Additionally, fat-derived inflammatory mediators may directly impair beta cell function. The clinical consequence is that individuals with pancreatic fat accumulation demonstrate reduced first-phase insulin secretion, which is the rapid insulin release that normally occurs within minutes of glucose elevation. This impaired early insulin response results in higher postprandial glucose excursions and contributes to the development of glucose intolerance and type 2 diabetes. Pancreatic fat accumulation has been documented in normal weight individuals, particularly those with metabolically obese normal weight phenotype characterized by elevated body fat percentage despite normal body mass index. Studies using magnetic resonance imaging have shown that pancreatic fat content correlates more strongly with metabolic dysfunction markers, including insulin resistance and glucose intolerance, than does body mass index. This suggests that ectopic fat deposition in the pancreas represents an important mechanism through which normal weight individuals develop diabetes, and that body mass index-based screening may fail to identify individuals at high risk for beta cell failure and diabetes development. The fifth mechanism involves the relationship between muscle mass, metabolic rate, and fat accumulation in normal weight individuals. Skeletal muscle is metabolically active tissue that accounts for a substantial portion of resting energy expenditure. Individuals with higher muscle mass have higher basal metabolic rates, meaning they expend more calories at rest and during activity. This provides metabolic flexibility, allowing higher calorie intake without weight gain and promoting insulin sensitivity through mechanisms including improved glucose disposal capacity and enhanced fat oxidation. Conversely, individuals with low muscle mass have reduced metabolic rates, meaning they require fewer calories to maintain weight and have reduced capacity for glucose and fat metabolism. Sarcopenic obesity refers to the condition where low muscle mass coexists with elevated fat mass. This can occur at normal body weight when muscle loss is accompanied by fat gain such that total weight remains stable. The metabolic consequences are severe because the individual loses the metabolic benefits of muscle tissue while gaining the metabolic impairments associated with excess adiposity. Basal metabolic rate declines, insulin sensitivity deteriorates, inflammatory markers rise, and physical function declines. These individuals often present with normal body mass index that obscures the unfavorable body composition, driving metabolic dysfunction. The development of sarcopenic obesity can occur through several pathways. Aging naturally involves some muscle loss and some fat gain if dietary and activity patterns are not adjusted to maintain muscle mass. Calorie restriction for weight loss, particularly when protein intake is inadequate and resistance exercise is absent, promotes muscle loss along with fat loss, potentially worsening body composition even as weight declines. Sedentary behavior promotes muscle atrophy while providing insufficient stimulus for fat oxidation, creating conditions favorable for muscle loss and fat retention. The combination of these factors means that individuals can maintain stable normal weight throughout adulthood while experiencing progressive deterioration of body composition toward lower muscle mass and higher fat percentage, particularly higher visceral and ectopic fat. When we understand the mechanisms through which body fat percentage and distribution determine metabolic health independent of total weight, we simultaneously understand what interventions actually improve metabolic health. Metabolic optimization occurs when several conditions are established. First, hepatic fat content must be reduced through dietary modifications that limit de novo lipogenesis and promote fat oxidation. Second, visceral adiposity must be reduced through calorie management and activity patterns that preferentially mobilize visceral fat stores. Third, muscle mass must be maintained or increased through resistance exercise and adequate protein intake to preserve insulin sensitivity and metabolic rate. Fourth, intramyocellular lipid must be reduced through improved insulin sensitivity and enhanced muscle oxidative capacity. Fifth, overall body composition must shift toward higher lean mass percentage and lower fat percentage, regardless of whether total weight changes substantially. Resistance training represents one of the most effective interventions for improving body composition and metabolic health in normal weight individuals with elevated body fat percentage. Resistance exercise provides the stimulus for muscle protein synthesis and muscle hypertrophy, increasing lean tissue mass and reducing body fat percentage even when total weight remains stable. The increased muscle mass improves insulin sensitivity through multiple mechanisms, including expanded glucose disposal capacity, enhanced expression of glucose transporters, and improved mitochondrial function. Resistance training also promotes preferential mobilization of visceral fat stores compared to subcutaneous fat, helping to reduce the metabolically harmful visceral adiposity that drives disease risk. The metabolic benefits of resistance training extend beyond body composition changes. Regular resistance exercise improves hepatic insulin sensitivity and reduces hepatic fat content independent of weight loss. It enhances muscle oxidative capacity, reducing intramyocellular lipid accumulation. It reduces systemic inflammation and improves lipid profiles. Studies have demonstrated that resistance training improves metabolic markers, including fasting glucose, insulin sensitivity, and hemoglobin A1C in individuals across the body mass index spectrum, including those with normal weight but elevated body fat percentage. The key is implementing progressive resistance training with sufficient volume and intensity to stimulate muscle adaptation, typically requiring training 2 to 3 times per week, targeting all major muscle groups. Protein intake optimization supports the preservation and growth of lean tissue mass while facilitating fat loss when combined with appropriate calorie management. Protein provides the amino acids required for muscle protein synthesis, and higher protein intake has been shown to enhance muscle preservation during calorie restriction and to promote greater muscle gain during resistance training compared to lower protein intake. Additionally, protein has high satiety value, meaning it promotes fullness and reduces subsequent calorie intake more effectively than carbohydrate or fat. This facilitates calorie management without requiring conscious restriction, as appetite naturally aligns better with energy needs when protein intake is adequate. The optimal protein intake for body composition improvement appears to be substantially higher than current dietary recommendations, which were established primarily to prevent deficiency rather than to optimize body composition and metabolic health. Research suggests that intakes in the range of 1.6 to 2.2 grams per kilogram of body weight daily support optimal muscle maintenance and growth in individuals engaging in resistance training. This protein should be distributed across meals rather than concentrated at a single meal, as muscle protein synthesis rates are maximized when protein intake is spread throughout the day. For normal weight individuals seeking to reduce body fat percentage while maintaining or increasing muscle mass, high protein intake combined with resistance training represents a foundational strategy that addresses the core body composition issues driving metabolic dysfunction. Dietary modifications that reduce hepatic de novo lipogenesis directly address one of the primary drivers of ectopic fat accumulation. Refined carbohydrates and added sugars, particularly fructose, are preferentially metabolized in the liver and converted to fat when consumed in excess of immediate energy needs. Reducing intake of these nutrients decreases the substrate availability for hepatic fat synthesis and allows existing hepatic fat to be mobilized and oxidized. Studies have shown that reductions in refined carbohydrate and sugar intake can produce significant decreases in hepatic fat content within weeks, even in the absence of substantial weight loss. The metabolic improvements follow rapidly, with enhanced hepatic insulin sensitivity and improved glucose regulation occurring as liver fat declines. The replacement nutrients matter significantly when reducing refined carbohydrates and sugars. Replacing these nutrients with additional protein provides the benefits discussed previously. Replacing them with fiber-rich whole food carbohydrate sources, such as vegetables, legumes, and intact grains, provides beneficial effects on satiety, glucose regulation, and gut microbiome composition, while avoiding the hepatic lipogenesis promoted by refined carbohydrates. Replacing them with healthy fats from sources such as nuts, olive oil, and fatty fish provides energy without promoting insulin resistance and supplies omega-3 fatty acids that reduce inflammation. The key principle is that carbohydrate quality matters as much as quantity, and that reducing refined carbohydrates while maintaining adequate protein and micronutrient intake addresses metabolic dysfunction more effectively than simply restricting total calories.